welcome back to Keeping It Together podcast, where we celebrate Indigenous resilience and creativity and learning more about health and wellness by engaging with pretty cool guests. And we asked the question, how did you keep it together during the COVID-19 pandemic? The idea is for us to learn and share ways of being resilient and do so by connecting with people across Alberta, across Canada. Today, we have a special episode. We have a great opportunity to speak with Dr. Leah Mayo, who is a human behavioural pharmacologist. So you can tell me if I get this all wrong and correct me. Leah is an assistant professor in the Department of Psychiatry at the University of Calgary. Leah holds the position of Parker Psychedelic Research Chair in the Department of Psychiatry in the Hotchkiss Brain Institute and the Matheson Center for Mental Health Research at the University of Calgary. So this will be some of the things we'll chat about today. So welcome, Leah. I'm really happy that you can join today. I'm really excited to be able to chat with you. I think in the bigger picture of having connection with other Indigenous researchers within our institution, this is really a great chance for me to get to know you, and love to be able to make lots of connections over the course of your career here.
Thanks so much for the invitation too. It's nice to get to chat with people, especially in a kind of semi-formal, more kind of fun conversation than you're used to when you're starting as faculty. So I'm looking forward to it.
Oh yeah, too bad we couldn't do this over a lunch.
Yeah.
have some food and hang out, but maybe we can all do that sometime soon. So tell us a bit about yourself. Who are you? Where are you from? And how did you end up in this field of work?
Well, so where I'm from is probably the easiest one to answer. So I'm from the Upper Peninsula of Michigan. So it's up on Lake Superior, very tiny town. I grew up on the L'Anse Indian Reservation as part of the Keweenaw Bay Indian Community. So my entire extended family still lives in the small little town we grew up in. And of my family, I was the first one to go to university. After that, others have followed. So at the time, kind of had no idea what I was doing, but was able to go to University of Michigan for my undergrad degree in neuroscience. Then I went to University of Chicago for a PhD in neurobiology. And during this time, I was really interested in trying to use what kind of skills and strengths I thought I had to address some of the issues that I saw a lot in my community. And that was really high rates of kind of severe mental health concerns and not always great access to mental health treatments. So that kind of is what has started me in this area of research, looking for kind of novel pharmacotherapeutic interventions, particularly in populations with high rates of trauma and stress that can contribute to things like PTSD and substance use disorders long term.
Thanks.
Yeah, so that's kind of the background. Was there more to the question? I already forgot.
I forgot as well. I guess that sounds really cool and interesting. And how did this come? How did you what was your inspiration to come into the field? I hear you say you wanted to help with mental health. I always think back to what inspired me to think about medicine as a career and whether or not I could do it. I was just kind of interested in that as well.
Yeah, I mean, I think a lot of things that I had this kind of like disconnect with things I was learning in class and what I felt was kind of my lived experience about kind of how people think of like the issue with psychiatric disorders and how it's often placed like as a burden on the individual, like the individual didn't engage with the treatment and the individual didn't do X, Y, and Z. And from my perspective, it was really it often boiled down to like a matter of resources or knowledge or really like connecting with the healthcare provider. So I thought that kind of some of the ways that we were thinking about mental health treatment didn't really resonate with, what people in my community and, from other kind of communities like mine would experience where, we don't, there's a kind of a one-off like, yo, I'll go to therapy. It's like, well, we would love to go to therapy, but we don't have like enough, therapists in the communities where we need them. So I think that kind of being educated at the university level wasn't really kind of meshing with a lot of the experience that I had coming from where I grew up.
So that resonates with me. I think we require many approaches to addressing all of the health issues and mental health issues that we experience as Indigenous peoples. We need people on the front lines. We need people creating knowledge, right? We need
Hmm.
people helping to translate that knowledge so the system can change and advocate for change in better ways. So that totally resonates with me. And as a family doctor, I fully experience the lack of resources to help people that are struggling
Hmm.
and 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 often have to be creative and and patch together those things that will help. But the reality is that there's a lot of hardship out there and not a lot of resources. And the resources that are out there often are not geared for us, right? Whether
Hmm.
it's culturally bound or it's because of unsafety, but or approaches to wellness that's not in line with how we see the world, right? So
Hmm.
there's so much to do and so much to build. So super thankful for you to jump into this and be a part of this field. The field of neuroscience is pretty amazing. It's uh, it's I engage with it from just a literature point of view to understand what's going on and what knowledge is out there, and so it's super fascinating. So you focus on a specific aspect of neuroscience. Can you tell us a bit more about that?
Yeah, so so my focus is really on kind of pharmacology and understanding how different drugs influence behavior. And I intentionally use the word drug very vaguely. Sometimes we're talking about drugs that people might use recreationally. Sometimes we're talking about drugs that are prescribed therapeutically, and sometimes there's an overlap between those things. Um, so what we're really interested in is trying to figure out the mechanisms of how do these different drugs influence behavior, and how can we use that when we think about clinical populations who may have dysregulation in certain behaviors. So sometimes we'll study how do drugs affect your stress reactivity to understand would this be a treatment for people who have an anxiety disorder or PTSD. And just through kind of random chance and a kind of dissatisfaction with the current treatments available, we ventured a lot into kind of newer fields of pharmacology, so particularly cannabinoid drugs and psychedelic drugs. Um, so kind of getting tired with the things that were available and trying to see, can we think outside the box? Can we use something that isn't currently used as a treatment, but try to rethink it so that it is clinically effective?
Yeah, that's interesting. I see a an emerging a reintroduction to these medicines that are that have asked us to shift our perspectives as a profession and as a society. Um, what have you seen in that in terms of the shifting that people have to do? Because there's a stigma connected to these medicines.
Yeah, and I think that's still quite pervasive, like even in kind of within psychiatry. I think one of the things is in, like psychedelics and that were used kind of back in the 50s and 60s, and then they fell out of favor for various reasons. And I think psychiatry took this shift where it was thought that we were going to find some like magic pill that you give people and suddenly you like fix their brain, right? And it turns out like that it just doesn't work like that. It's so much more complicated. So one of the things that's really interesting with psychedelics and cannabinoids and the way that we're using them, not the way that everyone's using them, but the way that we approach them, is that we combine them with therapy. Um, so that what you're doing is you're just doing like a short intervention, 1 or 2 doses combined with therapy, And that's kind of the extent of the treatment. We aren't saying, you should regularly dose people with these medications or anything. It's all under very supervised conditions, with a psychologist or a therapist. And really what it is kind of a way to get people to engage with therapy in a way that they might not want to or be able to or kind of know how to do on their own. And this can happen a lot of people. Sometimes people, if they have really severe trauma in their background, even just talking about the trauma can be really difficult. And what we've seen is with some of the medications that we've been using is that we're kind of lowering that barrier for people to engage with the therapy. And then that makes it a kind of more productive and effective session.
So that's an interesting sort of focus, because it feels that that we stick a person on the usual medications, and there's quite a long-term utilization of it. And I'm hearing a different message, that this is helps people to get over thresholds so they can engage with the ways of knowing and doing and being to help to facilitate a different outcome. Um, did
Yeah,
you hear my dog
exactly.
bark there? Sorry.
Yeah.
Must be a squirrel outside. All right. So stress and trauma is a big deal in our community. Yeah, like I mean, I can speak from as a family doctor who's seen like lots of people, and see it in my community just generally, and see it in family, and the nature of that trauma and the nature of that stress is super complex, right? The social
Hmm.
factors that are all related, whether it's resources, meaning stress from poverty, which is a big, huge inequity or social thing.
Hmm.
All these violences that have been imposed on us because of inequity and colonization and all that stuff operates through various pathways, so whether it's resources or within relationships that we have in with each other, in terms of within families, communities, and outside with the mainstream society. There's a lot of stuff out there that super complex, super impactful things that when together makes it very hard for us. What have been your learnings to addressing stress and trauma? And um, maybe it's a big complex question, but I guess I just kind of want your thoughts on this whole matter, and what does it mean from an Indigenous perspective? Like, what do we
Yeah, I mean,
do?
this is a really tough one for me to answer because I don't think I have a good answer. It's still something I feel like still something I'm kind of navigating on two levels, like scientifically, what do we do about it? But then also kind of personally, what do we do about it? Um, and yeah, I don't think I have like a really great answer about like how to address it. A lot of what we're trying to do is to kind of look for what might make people particularly vulnerable to their stressors. Because we know, I mean, nowhere will people grow up without stress. We don't want that. You want to be challenged in some way. But it's kind of a mystery as to why some people are able to navigate that and some people aren't. And I think this is kind of really what started me interested in research, because for instance, I grew up, with a very close family member who's my cousin. We were 4 months apart. We grew up next door to each other. We essentially shared an environment. We shared genetics, and we ended up going on very different paths. And that was kind of one of the first things that really got me interested into neuroscience is what's different about us that put us on these very different trajectories. Um, and while there's some small things that might impact us, we still don't really have a great answer for that. But I think one thing that people really are starting to realize, and it took a bit of time to get into neuroscience, is really the importance of social support. Um, you can't change a lot about some of the resources that you have access to or kind of where you are or things like that, but really building a community seems to be one of the most kind of protective factors in these sorts of kind of dealing with stress long term. Um, And even I think in Iceland, there's like a really nice example where they offered kids kind of this kind of community building opportunity as a way to kind of curb their kind of experimentation with like recreational drugs. And it became this huge success where, having instilling that sense of community and that social support in children really helped them in these very kind of tumultuous kind of early adulthood years.
So where were you during this COVID pandemic?
So I was in Sweden,
Ah,
and I was very pregnant with twins. Well, actually, no, by the time the pandemic hit, they were born. So my twins were born February 2020. So a
ah,
month before everything really kind of went wild. And it was really interesting at the time because one of my closest friends in Sweden that I worked with, she's Italian, and her family was in the region in Italy where COVID initially was kind of erupting. So
yeah.
kind of like hearing that, but then also like I'm stressed about the fact that I'm gonna have two newborns soon, like not really putting it together. And it was a really interesting time because we had considered before they were born if we're going to move back to the US, and just because of healthcare in the US and all that and parental leave in the US, we decided staying in Sweden would be a better choice. And we had arranged that like for every month for the first 6 months, we would have, 1 month my mom would come, 1 month his mom would come, then my sister would come. So we would have kind of a community there. Um, Turns out that didn't happen because of the travel restrictions that were put in place. It was the day my mother-in-law was supposed to get on the flight was the day they put the travel restrictions in place. So it went from this very well thought out plan to like absolute chaos. um,
Uh,
so it was just my husband and I trying to figure out. I mean, we were new parents. All of our family was in a different country. And I think that's the point where I realized that, like, that whole, like, it takes a village saying. Because for me, I grew up on a reservation where my entire family is. So there was always someone there to do whatever needed to be done, right? Someone comes and watches a kid for a few hours or picks them up or does this or does that. But like being on the total opposite end of the spectrum where there is literally no one, it was not at all what I had planned or thought it would be like.
how did you? What were your strategies to address the the need to just get through it? I mean, by yourself, you
Um,
and your husband, two kids.
yeah, well, the first thing is we prioritized sleep, as like new parents often do. But literally, it was just like making sure that we're slept so that we're functional and we stay healthy. Um, Lots of like walking outdoors all the time when we could, just to see things besides the inside of our small apartment at the time. Um, and then a lot of like Skyping, like, video calls with our families. I mean, we had our babies were little newborns. They were kind of little lumps. They didn't really do much at that point, but just, I mean, there were times where it's just they were on the phone and it was not really even saying much, but just feeling like there was a presence of other people around. Sweden took a unique response to COVID. There were never any mask mandates in place. I still don't believe that aerosol transmission is a thing. And they interpreted some of their kind of national laws that they weren't allowed to mandate like people staying home. So there was this kind of added level of stress. And I talked to a lot of my colleagues who were there with us because we were all researchers, most coming from outside of Sweden, and we would see all the restrictions in place in our own countries and how people were dealing with that. But in Sweden, it was different. And we did work from home for a while, but there was, again, no mask mandates required or anything like that. So there was this kind of stress of like being uncomfortable because the country as a whole wasn't taking precautions in the way that other places were, and you're kind of caught in the middle being like, well, I think that I want to be a little bit more safe, but it wasn't really set up in a way that we could do that. So even trying to make sure that when we did go back, that my lab staff could wear masks when they interact with participants, like this was a thing that I
Uh,
had to discuss. um, so it kind of made it even more stressful that I felt like people weren't taking it quite as seriously. Um,
Yeah.
and yeah, so it ended up being a really challenging situation for that reason. Um, and because of that, even when there were those brief periods where like people would say COVID's over, and then it wasn't because we'd have another resurgence, but we still didn't get to have a babysitter come over and watch the kids because we knew people weren't really taking a lot of the safety precautions that we would have hoped they were. So we didn't want to take that risk. So then we would have to stay home, even if we had
Hmm.
the time to do something.
Yeah. Very interesting. What were the rates in Sweden?
I don't remember the rates. I know there was just a article out, I don't know, in like Science or Nature, and like Sweden did bad. It's strange
Yeah.
sometimes if you talk to them, they still don't think they think that the decisions that were made were right. But I think the average age dropped by like 8 years or something. It was
Oh,
yeah, it's
wow.
something wild.
Like the life expectancy had dropped by 8 years.
Yeah, yeah.
Yeah.
So, I mean, and it was kind of like one thing with Sweden compared to other countries, particularly in North America and in more densely areas of Europe, is that there's not a lot of big cities. I mean, there are. My city that I was in was the fourth largest city in Sweden, and it's like 150,000 people. So it's a big city, but it's not, these millions of people in one small city. So, places like in Stockholm where, you do hit that million mark, they got hit way harder than, smaller towns like where I was.
So do you figure that in the model of the use of psychedelics, the nature of the counseling or the mental health sort of talk component is the same, or is there an adaptation that you guys in this field are using, like different than cognitive behavioral therapy or dialectical behavioral
Yeah,
therapy,
so
or
this is like a huge area of interest and um, sometimes concern, I think, is that depending on the specific trial, some people just kind of do what they think is best, and maybe not it's not as kind of manualized or structured as sometimes psychotherapy is. And we really want to veer into sticking to things that we know have some efficacy and know that people are being trained on, because again, if we want this to be accessible to patients, we need to make sure that healthcare providers can provide it. And if we come up with some brand new type of therapy, then we have to train that brand new type of therapy for everyone. And, people don't have the time for that. So we're really trying to make sure that, we're sticking to things that we know are learned often. I mean, there is the added psychedelic component, but that's a small piece of what the entire treatment is. So in various trials, we've incorporated kind of very structured prolonged exposure therapy for PTSD, motivational enhancement therapy for substance use disorders. So things people are already trained on, and they're just applying that into this context.
from an indigenous background of some psychedelics? What are your thoughts on on traditional knowledge that has been using some of these medicines for millennia? And where are we at from an indigenous perspective in contributing to this possibility?
Yeah, so I mean, I think a lot of that for a while wasn't really appreciated. That there are people who hold this knowledge that have been doing these things for a long time. So there, as sometimes happens, there was a big disconnect between kind of the more indigenous perspectives and the kind of Western biomedical clinical trial machine. But I think now, a lot of kind of some of the thoughts are becoming a little bit more well integrated, particularly as people realize kind of the importance of the set and the setting that you're in. It's not just the medicine, it's where you are physically and mentally as you start this. It's not so much the standard kind of sit down in your doctor's office and you're prescribed a thing and you take it and that's it, but there's a lot of preparation that goes into it. And I think that's important because you really want to make sure people are kind of in the right state of mind and they know what to expect, they know what they might experience. And that they kind of take their time and ease into it. And I think that's one of the ways that um, it's kind of made some people uncomfortable the way it's kind of diverged a bit from the standard way we do clinical trials, but it appears to be a really important part of it too.
Hmm. I think I can see a ton of important knowledge that traditional people who have used this and passed down this knowledge from generation to generation that a psychiatrist might not comprehend in terms of the interconnectedness of the medicine. And from a bigger holistic spiritual point of view, there's a lot of learnings. I have some fears of the extractiveness of Western science when they realize there is critical knowledge there. Let us grab that and make it our own, right? Um, I think I can envision there's got to be like some critical Indigenous researchers that have to help community to protect that knowledge. But the idea
Hmm.
of sharing it is really important at the same time.
Yeah, yeah, definitely. I mean, I think that's something, you know, I don't think in psychedelics there's kind of a unique spin to it, but it's kind of a story that we know, right? This is information that's been passed down a lot, and how can we incorporate it into what people are doing in Western medicine in a way that's still respectful, but you know, taking advantage of all of the wisdom and knowledge.
Yeah,
And I think it kind of does sometimes make people uncomfortable. In Alberta, recently, they just passed regulations to say that for psychedelic therapy, you know, there has to be a psychiatrist who's doing the prescribing, which I kind of understand from. You know, one point that if it's a psychiatric intervention, that's one thing. But, you know, so far, no physicians are getting medical training on psychedelics. So who's to say that this person is the most qualified because they're a psychiatrist when they haven't been trained on any of this in their medical training? And I think
mhm,
that's going to be a huge gap is what do we meet, like how do we train people in a way that's effective and taking in all this knowledge to account, because our current kind of Western way of doing medical school doesn't have that. So
no,
what are we going to do in the meantime?
yeah. Our curriculums are jam packed with everything else at the moment. So, all right. So, thanks a lot,
Yep.
Leah. It's been a pleasure to chat with you and officially interview for our podcast. Thanks so much for joining us today, Leah. And to all our viewers and listeners, feel free to connect to our podcast, listen, share them with family and friends, and hopefully these resources, these podcasts, these things will be things that you can take on and be a part of your life to help us all as Indigenous peoples to be well. And in the meantime, take care. Have a great day. And thanks again, Leah.
Yep. Thank you.